We can go ahead and get started. So good morning, everybody. Thank you for joining us. Before we get started, I wanted to mention the last week's recording slides and resources are available on our website. Please feel free to check that out at your convenience. And without further ado, I'd like to introduce our speaker, Dr. Henry Fremow, who is the member of Division of Infectious Diseases and the hospital epidemiologist at Cooper University Hospital in Camden, New Jersey. He has been the senior medical consultant for the Camden County and Southern New Jersey Regional Chest Clinic since 2001. He's also the founding member of the State of New Jersey TB Medical Advisory Board. He has particular interest in management of HIV and TB co-infection. He's also one of our volunteer consultants at GTBI. We're very grateful that he's able to join and give this talk today. Thank you so much, Dr. Fremow.
Well, thank you for inviting me to do this. Let me just bring up my slides here. And can you all see the slides out there?
Yes, we can see the slides.
Okay. So what we are going to be talking about for the next hour or so is really about how we monitor people who are on treatment for TB infection and TB disease, and sort of talk about the basis for a lot of the recommendations for what we do and why we do them. And during the course of this, we'll go through a couple of cases and sort of discuss what's happening with them. And I believe there are some poll questions in here too that will pop up from time to time. So let's start. And I always like to start with a little bit of a historical perspective, because for those of you who may be relatively new to tuberculosis, tuberculosis is obviously an old disease and is a disease that has a long history of both public health and societal impact in the United States. I was actually surprised a couple of years ago, talking to my son, who is not in medicine. He's in law. He's in his early 30s and has really not a whole lot of medical exposure, but knew surprisingly a lot more than I expected him to know about tuberculosis 100 years ago. And it turns out that he learned everything he knows about tuberculosis from playing the video game Red Dead Redemption 2. You know, I'm not much of a video gamer. However, my understanding is that this actually provides a very realistic portrayal of what it was like to have a chronic illness, especially one at the time that was incurable back in the day. You can actually see during the course of the video game, this is when our protagonist actually becomes infected with tuberculosis during the course of a fight. You can see him there wiping the tuberculosis off of his face. And then here a little later in the game, you can see him showing up at a doctor's and being diagnosed with consumption or tuberculosis. So the game takes place in around 1899. And in most of the adventures that you can choose in this game, they all have the same outcome. His TB doesn't get treated, and no surprise, he eventually dies. In one of the adventures you can choose, he does get some treatment, gets ginseng, English mace, and yarrow, which surprisingly didn't help him all that much, and still ends up dying regardless. And the monitoring that takes place during what they did in standard of care in 1899, they basically watch to see what happens. So let's fast forward 30 more years to the United States in the late 1920s. And this is treatment and monitoring for TB disease in the late 1920s. This is a picture of one of the porches in the sanitariums in Saranac Lake, which became one of the areas where many sanatoriums popped up around that time. And the treatment then was healthy food, fresh air. That's why they're all bundled up, sitting out in the cold on the porch. And again, monitoring basically consisted of feeding them and watching them. All right, so let's move on another 100 years or so. Here we are in the 2020s, and you can see things have changed quite a bit. On the left on the slide, you see the evolution of antimicrobial therapy for tuberculosis, starting in the 1940s with streptomycin, which for those of you who are New Jerseyites, this is actually the organism that produces streptomycin is our state microbe. And since then, many, many, many drugs. So here we are 100 years later, and the good news is that we can treat tuberculosis much more effectively than just a bunch of herbs or fresh air and good food. And there is much, much less tuberculosis, especially in the United States. However, the patients that we see are more complicated. We are now dealing once again with the challenge of drug resistance. And there is also, and the reason that many of you are actually taking this TB 101 session is that there is a lot less expertise in the treatment of tuberculosis. Many of the providers, from public health nurses to physicians who have been involved in TB treatment over the years, have retired. So it's really time for new people to step forward and learn how to manage the treatment and the monitoring of people who are on treatment for tuberculosis. All right, so I'm pretty simplistic in how I think. So when I look at what happens when you start somebody on tuberculosis therapy, there's only a couple of options. So let's start with when you're on treatment for TB infection or latent TB. Those people generally are not symptomatic when they start. So what we hope happens is that they stay the same because they're not symptomatic to start with, and we don't hope they don't become symptomatic. Occasionally they will get worse, and if they get worse, the main reason they get worse is because they have adverse effects of therapy, and that's what we have to monitor for. Very rarely we will see somebody who is started on treatment for TB infection, but in fact has TB disease, and they actually get worse because of unsuspected TB. That's why our evaluations that we do for people with TB infection are to make sure we find those people who might have TB disease and make sure we don't just start them on treatment for TB infection. On the other hand, if you have started on treatment for TB disease, a lot of different things can happen. One is that they get better, and this is obviously what we hope for. But they might stay the same and not really improve. And sometimes they may even get worse, or they may get better in some ways and worse than others. And our challenge is to try and figure that out. The people who just get started on treatment and get better, we love those folks because they make our job easy. But not everybody falls into that category. So why isn't my patient getting any better, or maybe even getting worse? I kind of break it down into two different issues here. The first are related to medication, and a lot of different reasons why people might not be getting better related to medication. One is they may not be taking the drugs. That theoretically shouldn't happen if they are on directly observed therapy. but there are still instances where it might. It's possible we're not giving them high enough drug doses, or they're not absorbing the drugs, or they have drug resistance that we don't know about. It's possible they're getting worse from medication because our TB medications are interacting with other medications they're taking. And then probably the most common reason is drug toxicity or adverse drug reactions. But medication issues are only one bucket. The other bucket are things related to their TB disease. Sometimes people are really, really sick with their tuberculosis, and it takes a while for them to start to get better. And they may get worse in the interim. They may develop new complications of their disease as their disease progresses before the medications have a chance to work. Sometimes they have TB in more places than we realize, and some of those other sites may not show up until they're actually started on treatment. One thing that I don't know if you've talked about yet, but we'll be talking about, is IRIS, or immune reconstitution inflammatory syndrome, something we see a lot in people who are co-infected with HIV and tuberculosis, but can happen in other populations as well. In people who are sick and then start to get better, is that as they're immunologically better, they're mounting more of an inflammatory response to their disease, and that can present as worsening symptoms. And sometimes they have disease that's not going to get better unless we operate on it. And that's not super common, but it certainly can happen. All right, so let's talk about our toolkit for how we monitor responses to treatment. What are the tools that we have as we follow people once we start them on medication? Obviously, as we see people over time, we're going to talk to them, and they're going to give us some information, and we may examine them. And so what are the things that we might be thinking about? And these are questions that we'll come back to as we talk through some patients. But what are some of the objective components that we look for? Are things like, is our patient gaining weight? Is our patient, are they no longer having fevers, or are their fevers better? Are they coughing less? Those are all sort of the parameters that we'll be following as they go through their treatment. But you have to ask, and you don't assume that the patient's necessarily going to tell you. The other tools we have are sputums, and we'll talk about how often we might want to get sputums and how we might interpret those results. Occasionally, we will get chest x-rays. If it's extrapulmonary disease and not pulmonary TBs, you may need to get images of other places. Like if they have tuberculosis in the head and a tuberculoma there, you may need CAT scans or MRIs to tell whether or not they're getting better. And then we'll talk about laboratory monitoring. All right, so how often do we monitor people once we start them on treatment? If we're treating people for TB disease, the recommendations are that evaluation should be performed at least monthly. Now, we obviously don't necessarily see everyone every month. And I know that in our clinic, and people who are doing well on treatment and are well into their treatment course and are getting monitored through, and their treatment is being monitored through some form of directly observed therapy, they may not necessarily be seen monthly, and we may space out those visits, but certainly early on in the evaluation, we're going to want to see them monthly. And to test our treatment efficacy, we're going to ask about symptoms of their TB disease and how those are doing. And obviously, you all know now the symptoms of tuberculosis. The one that we pay a lot of attention to is actually weight, because as people are getting better, we would expect them, especially if weight loss was a part of their disease to begin with, we would like to see that they're gaining weight and improving. We're going to look for organ-specific symptoms if we're monitoring extrapulmonary disease. If somebody's got bone or joint tuberculosis, we want to know if their swelling is better, if their pain is better. And we already talked about the weight. The other reason why we follow their weight is because sometimes as people gain weight, they need a higher dose of medications. So we want to make sure that our dosing is catching up with where the patient actually is in the course of their treatment. And it's important to recognize that some people get better really quickly, and it's like in a week or two, it's like they're fine, but other people are going to get better much more slowly. But if you are not improving at all in those initial 2 months, then you have to start thinking about other causes of treatment failure. And we will always, as we monitor, besides asking about symptoms of their TB disease, are going to be monitoring for symptoms of adverse effects of their therapy, and we'll come back to that a little bit later on. So let's start with microbiologic monitoring. We generally collect sputums, specimens at least monthly for smear and culture. And we'll continue to do that until we have two consecutive specimens that are smear and culture negative. And that's important to recognize. The one challenge with this is that some people, after the first couple weeks of treatment, may not be coughing anymore and may not be able to produce sputum. That's obviously a good thing, but sometimes it makes it more challenging to prove that they're microbiologically negative. And we can talk about that later on. The most important cultures are the ones at 2 months, because whether or not they still are growing organisms at 2 months is that determination of how long their length of treatment is going to be if they're on standard medications. And it's not the smear that's important, it's that culture that's important. The other thing that we obviously want is drug susceptibility testing, at least at baseline when they start treatment. And we'll talk about when you might want to get repeat drug susceptibility testing, which is really if they are still culture positive at 3 months. So this is what we'd like to see. This is a patient who started on treatment, had a 1+ positive smear that grew tuberculosis. You can see that about, I guess that's about 2.5 weeks later, they are now smear negative, but their culture is positive still because it may take longer for the cultures to sterilize than for the smears to become negative, although sometimes it's the opposite. And then by about 6 weeks of therapy, everything is negative. So that's the kind of result we like to see. Just as an aside here, there are times when we are collecting sputums more often, and usually that is being done not for assessing effectiveness of treatment, but that's when you need to document that they are smear negative for public health reasons. We recently had a patient in our region who was a merchant working on a merchant ship where he was diagnosed and then hospitalized, was then removed, able to go from the hospital to a hotel room, but remained persistently smear positive for a fairly prolonged period of time, and was not going to be able to get on a plane and fly back to his home country until we were able to document negative smears. So that's an instance where you're going to be getting smears more often than we typically do, which is generally every month or so. All right, so that's obviously the kind of pattern that we like. What about this pattern? This is a patient who started at that same date, had a much heavier organism burden. You can see that they are 3+ at the start of treatment, and still 3+. Here we are out at 2 months in March, after they've been on treatment, still growing TB, still smear positive, and still have positive cultures. And even a month later, which is now 3 months into treatment, they're still still smear positive, although lower numbers, and their cultures are pending. So what does this mean, and should we be worried? So let's talk about our first case. This is somebody who was recently diagnosed at our hospital a couple of years ago. 69-year-old, born in the United States, presented with 9 months history of about a 50-pound weight loss, with fevers, night sweats, and worsening of his chronic cough. He was a heavy smoker, was admitted to the hospital, and his initial sputum specimens were 4+ AFP positive, and he was started on right. And there you can see on the left is his chest X-ray. You can see a completely socked in. Let's see if, I don't know if you can see my arrow or not, but you can see in the upper right lung, on the X-ray, and then on the right, the CAT scan, a completely socked in right upper lobe with areas of cavitation. And on the left, he's got a pleural effusion there, and he's got although less disease, does have a cavitary lesion up there on the left upper lobe as well. So pretty sick guy, he's been sick for a long time, a lot of TB in his lungs. All right, so we send a GeneXpert, which obviously for us is a critically important tool, because at least from the beginning, it helps confirm the diagnosis of tuberculosis if they're smear positive, because that could be or things other than MTB. And it also helps us to know at least that they're not resistant to rifampin, because then we don't have to then immediately start to worry about whether or not they have multi-drug resistant disease. And often, since it's going to take a couple more weeks for the susceptibility data to come back, the GeneXpert is the only drug susceptibility data you may have, unless for other reasons you're going to be getting molecular susceptibility testing data. And we can talk about that at the end of the discussion, because there may be instances where we're particularly worried about drug resistance, where we use our resources to send off specimens either to the CDC, or depending on what state you're in, to one of the regional molecular reference labs that can do molecular detection of resistance. But most of the time, the only information we have in the beginning may be that GeneXpert result. All right, so we start our gentleman on right, and we fast forward 2 months now. He's still in the hospital. His cough's a little bit better, so that's reassuring. He's no longer febrile, but he's really not gaining any weight. And he had lost 50 pounds, and we would be hoping that he'd start to be gaining some weight now. He remains on right. He is now at about 8 weeks or 40 doses of his PZA. He still has sputum specimens that are still AFB smear positive. Because he's in the hospital and people are trying to get him out of an airborne isolation room, they're still collecting sputum on him weekly, and the lab is overrun with his samples, but he is showing no signs that he is getting ready to be taken out of isolation. All of the samples are growing MTB. We are obviously cultures lag behind smears, so it takes a while for a catch-up to occur. And we now know that his initial isolate is pan-susceptible. So should we worry that here at 2 months, he's still persistently sputum smear positive? What do you think? Is anybody worried?
You can raise your hand or put it in the chat as well.
And we'll come back to this question in a minute, but
All
see
right,
a lot of hands. Who's worried?
we do have some yeses in the chat.
Okay. All right. So some people are worried. I mean, I think we are at the point where maybe some of us are worried, maybe some of us not so much. All right. So during this time, he gets a follow-up X-ray because that's, again, one of the tools we have to help us. And you can see that maybe it looks a little bit better, especially in that right upper lobe. Not dramatically better, but a little bit better. So at least it doesn't look like there's anything worse going on. All right, so that was 2 months. Some people are worried, maybe others not so much. Here we are at 3 months of treatment. He's still smear positive. We now know he's culture positive up to 2 months. You can see that 3-7 culture, which is about 2 months after starting treatment, is still growing MTB. So are more of you worried now? Well, I think this would be a situation where most of us are at least a little bit worried, and maybe somewhat worried. And then so the question is, why do we think that he still has persistent positive sputum smears? Here we are at 3 months. And here we go on another month. Now we're at 4 months. We know his cultures are still positive at 3 months. And now getting into the 5th month, he's still smear positive. So if there's anybody who wasn't worried before, I would hope that maybe you would be at least a little bit worried now, and would be talking to some of your friends or those of us who might be able to provide expert consultation and try and figure out what might be going on. All right, so let's go to, I think this is my first poll question. So this is somebody who's got persistent positive sputum AFB smears at 4 months of treatment after starting on standard therapy for drug-susceptible TV. So which of the following might be most likely to explain why his smears aren't clearing? So there may be more than one right answer here, but which one do you think is the most likely explanation? We'll give you a minute to all vote. My answer there, and we'll see what you all think in a minute. Okay, so we have a lot of different thoughts here. Let's see how many of you have voted at this point. So have we closed the polls? Okay, so let's talk about, so I think that what's important here is that all of these might be things that you might think about. Some of them are more likely than others, and some of them are things that we do have tools to help us sort out. Right? So let's kind of go through these choices. So we already talked about the fact that people with extensive cavitary disease can take a long time to clear, and even on appropriate therapy. And we have, especially people who've been sick for a long time, high disease burden. And we've had people, I think the longest person we had who was smear positive in the hospital was about 6 months. Normally, these people may not need to stay in the hospital, but depending on where they might be able to go after discharge, some of these people can't be discharged from the hospital if they're smear positive. Obviously, we try and get these people out of the hospital if we can, especially if they're otherwise doing well and it's just their positive smears. But sometimes they're stuck because they can't go anywhere until their smears are negative. What about drug resistance? Well, theoretically, if they're in the hospital, they should be getting directly observed therapy and should be taking their medications. If they're not in the hospital, then they still should be getting some form of directly observed therapy, and we should be able to tell what's going on. But we want to make sure that they're getting an effective regimen. And as we talked about earlier, if you get to that 3rd month and they're still culture positive, this is when you want to make sure your susceptibilities are repeated. And occasionally there are people who may have a mixed drug population to begin with, and you may not find out about the resistance. Every once in a while, we have people who have discordance between their genotypic resistance and their phenotypic resistance. So you always want to think about resistance, but if they've been getting all their medications and are being monitored, then you theoretically should not be developing resistance on treatment. Poor absorption is, I think, one that we probably underestimate, and this would be an indication to check drug levels, because lower drug levels, and we'll talk more about this in a slide or two, do correlate with slow clinical responses. Doesn't necessarily mean that they will fail therapy, but it can contribute to a patient not responding as quickly as you'd like. And we'll talk about which groups are you particularly concerned about drug levels. One thing we do occasionally see, or we see people who have a mixed infection with tuberculosis and a non-tuberculous mycobacterium, especially if they have a lot of long-standing lung disease. And sometimes the TB is gone and the AFBs that we're seeing are non-tuberculous. And we also, when people cough samples up and we see organisms on smear, we don't know until that culture comes back as to whether or not those organisms are alive or dead. All right, so let's go back to our patient. So at 4 months, even though the smears are still positive, he is clinically doing better. We check drug levels, his rifampin drug level, and that typically is 2 hours post an oral dose is when we send that. His drug levels are low and his rifampin doses increase. And because of the fact that it took him a long time to clear, meaning he still had positive cultures at 3 months, we decide to treat him for a total of 9 months, meaning 2 months, meaning a 7-month continuation phase of therapy due to slow response and persistent positive cultures. And think about this question now, but we'll talk about it later on about why we would in him, since his cultures take longer to become negative, why do we extend that treatment course? All right, and this was his data. Actually, you can see that his 4-month, his 3-month cultures, one was positive, one was negative, and his 5-month cultures, I mean, his 4-month cultures are all negative, even though they're still smear positive, and his repeat susceptibilities show that he still had pan-susceptible disease. All right, so let's this is an opportunity to talk about drug level monitoring, or therapeutic drug monitoring, or TDM is the abbreviation that most people use. We know that drug levels on standard medication doses may be low. Certain populations may be more likely to have subtherapeutic drug levels, in particular diabetics, people who are HIV infected, people who may be malnourished or severely ill, may not be absorbing medications as well. And although we can't always prove that subtherapeutic levels are associated with treatment failure, they are associated with slower sputum sterilization rates, and prolonged smear positivity. So in any patient, especially in patients falling into those groups up above who have slower clinical responses, we will get therapeutic drug levels. The ones that I think are most useful, because they're also the ones most likely to be lower, are rifampin and isoniazid. And I can tell you, when we actually check rifampin levels in our patients, probably about half the time we end up having to increase their rifampin dose. And in fact, there are treatment trials now of tuberculosis that are ongoing, where they actually are using higher doses of rifampin than we've typically given patients. All right, another response to treatment tool we talked about radiographic evaluation. In patients with positive cultures, chest x-ray at 2 months of treatment can be helpful, but it's not always essential to their management. We generally in our clinic will get an end of treatment chest x-ray, and mostly that's because we want a new baseline for future comparison, especially in this day and age where you have a mobile population, people who may not be well integrated into the healthcare system and may show up somewhere else 2 years later with a history of telling their doctors that they had tuberculosis, and they're going to be reworked up for TB. And it's very helpful to have that chest x-ray at the end of their treatment for comparison. For people who are not getting better, an x-ray may be very helpful. Actually, let me go backwards. In a patient with a negative culture, with the 2-month x-ray is even more helpful, because we are looking for more evidence to help us support a diagnosis of TB. These are people who may have been started on treatment for high suspicion of TB disease. If they don't have cultures, we haven't proven they have TB, but about 20% of patients treated for pulmonary tuberculosis may not have positive cultures during their evaluation. And that 2-month chest x-ray may be helpful to show evidence that whatever was going on in their lungs may be getting better. Other reasons for repeating chest x-rays is if somebody either has worsening symptoms or changes on lung examination, because there are new things that can develop occasionally. You can have patients develop increasing pleural effusions. You can occasionally have a patient who will develop a pneumothorax from their extensive disease. You can have atelectasis from compression, or occasionally some of our patients with pulmonary TB may also have pericardial disease, and that heart may be becoming more enlarged. And this is a patient from our clinic, I think from a year or two ago, who had pretty extensive tuberculosis when he first showed up. You can see that he's got bilateral disease I believe he was also HIV co-infected and had not been taking his HIV treatment either. When he came back to the clinic, it may be hard to see on the X-ray, but a little easier to see on the CAT scan. You can see that that black there is pneumothorax. And you can see it here, that arrow is pointing to where you see black lung adjacent to the edge of the lung there. So in the setting of his extensive tuberculosis, he developed a pneumothorax and dropped his lung and ended up having to go to the hospital and get a chest tube to help re-expand that. So occasionally you'll see unexpected findings on those chest x-rays. So this is a summary of the standard monitorings for drug-susceptible TB, and it comes from the Treatment of Drug-Susceptible TB Guideline. You can see where you want microbiology, where you want sputum smears and sputum cultures, where you might want to get imaging, and some of the laboratory testing and some of the other clinical markers that we do. All right, so let's go back and talk just briefly about our patient. When do we decide to extend therapy beyond 6 months on patients on RIPE? And I have a list of reasons here, because turns out that although we would love everybody to be able to get 6 months of standard treatment and be done with their treatment at 6 months, there are a significant number who need the longer treatment course. If they don't get rifampin and pyrazinamide in their first 2 months of therapy, those people always will need a more prolonged treatment course, unless they're on some other regimen that I'm not talking about at the moment. If they have resistance issues, depending on what that resistance is and what treatment regimen they're on, it is likely that they will need a more prolonged treatment course, but not always. If they have positive sputum cultures at 2 months and cavitary disease, or if they're HIV positive, they don't have to have cavitary disease, just positive sputum cultures at 2 months, we're going to give them a more prolonged continuation phase of treatment. There are certain extrapulmonary syndromes, most importantly, central nervous system and spinal disease, and some of us, for patients with disseminated disease, will get treated with a longer course. If you are HIV positive with a low CD4 count and not on antiretroviral therapy, often those patients will also get a more prolonged course of therapy. And then there's clinical judgment, and every once in a while, we'll see somebody who's slow to respond, really sick, may not necessarily check one of the boxes above, but just from a clinical decision-making perspective, we may decide to give them the more prolonged treatment course. But most people that we're treating for 9 months instead of 6 generally have at least one of those indications up there. All right, how about treating for less than 6 months? Do we ever treat for less than 6 months? All right, you can type into the chat box if you want, and then we'll move on and talk about this in a second. In one box, and one person put something into the chat box.
Yes, they have seen it. And somebody else said we do not.
Okay, so there are a couple of reasons why we might treat people for less than 6 months. So the first scenario is, just give me 1 minute to get back to my slides here. If we are treating somebody for culture negative pulmonary disease, meaning they have some disease that looks like TB, we've done a good job of collecting sputums, they haven't grown it, they have a negative gene expert, so we haven't proven that it's TB, but it seems like TB. Those people can be treated with a 4-month course of therapy, 2 months of RIPE, and then you de-escalate to 2 months of just isoniazid and rifampin. And we do this occasionally. If they have more extensive disease, or the reason why we can't get good sampling is we don't have a positive culture, is we just never really got great sampling, those people we would probably still treat for 6 months. In drug-susceptible pulmonary tuberculosis, one of the things that's new is a 4-month treatment regimen, which is 4 months of rifapentine and moxifloxacin as sort of the backbone of that regimen. I can tell you this regimen's now been out there for approximately a year and a half, 2 years. There are still not a lot of clinicians using it for a couple of different reasons, but it is one of the treatment options in the appropriate patient. And we can talk more about that if you have questions at the end. The goal of treating tuberculosis, now you've all seen that TB infection, the treatment courses have gotten shorter and shorter. We now have, instead of 6 to 9 months for most patients, regimens that are 3 and 4 months. And the same is what we are trying to do in pulmonary tuberculosis. There are several different shorter course regimens that are in clinical trials now, because we all know that 6 months is a really long time to have people on medicine, and if it's possible to treat them shorter, we'd like to do that. All right, let's move on to our second case. This is a 63-year-old Vietnamese-born woman who's diagnosed with smear-positive pulmonary tuberculosis. Her gene expert is positive for MTB, and there's no rifampin resistance detected. She started on a standard 4-drug regimen of RIPE plus vitamin B6 and is getting DOT. And about 2 weeks into her treatment, she complains to the clinic nurse that her medications are making her sick. So she wants to stop them. What do you do now? Do you stop them? All right, so this is a good opportunity to talk about sort of the rest of the stuff I'm going to talk about is mostly about monitoring for adverse drug reactions from medications.
Got a
And
few.
monitor.
I just want to let you know I got a few no's. Investigate times of day, negotiate, and treat symptoms.
Right. So there's a lot of things that we can do. And we're going to talk a little bit about that, but unless we have clear evidence of drug toxicity that requires stopping medications, we generally don't want to stop their TB therapy. And we'll talk about that. So in monitoring for adverse drug reactions, this is a collaboration between our clients, us, and the TB program. A lot of this is education. We're going to educate our clients about potential serious adverse drug reactions from their regimen to make sure they tell us about them. But the challenge here, and I think that this is more of an art than a science, is how do you convey that risk without creating unnecessary anxiety? And this is something that you really have to sort of think about the person in front of you and how they best receive information. And are they someone who is going to worry about every symptom that you tell them about? Or is that somebody who, unless you tell them, you're not going to hear from them? until they get really sick. And you want to make sure you educate them about the need to report symptoms, but you should never presume that they're going to tell you. People always come in for their clinic visit in our clinic. They've been seen, been getting DOT every day. They're questioned every day about their symptoms. They say they don't have any, and then they come in for their clinic visit and have a half a dozen new symptoms. So don't be surprised, but never let it happen that it's because you didn't ask. But that's no guarantee they're going to tell you. And part of this is just educating our staff and making sure that everyone is aware of potential serious adverse drug reactions and assessing for those adverse drug reactions at each and every interaction and documenting those and communicating them. If you are heard about a symptom, unless you document that, then the next provider who's going to see them may not necessarily know that that's been a problem and may not follow up on it. And obviously, there's many opportunities to ask about this for patients on treatment for latent disease who are just coming in for medication pickups. Part of that pickup is asking them about any side effects or potential adverse symptoms. The other things that you want to do is you want to make sure that you know what other medications your client may be taking. And that includes both prescription and non-prescription medications, because those can interact with or potentially increase the risk of toxicity from our medications. You also want to make sure that you're communicating with their other prescribers, especially those who are on complicated medical regimens. One of the challenges we have is, although some of our HIV co-infected patients are seen by us in our HIV clinic, some of them are not, and their HIV providers may be making changes in their HIV regimen that may not play nicely with their tuberculosis regimens. Or if you have patients who are on treatment for substance abuse issues, particularly opioid use issues, it's important to know if they're being started on methadone, or if they've been on methadone and you're starting them on rifampin, that those interactions need to be at least communicated, even though they're not contraindications to therapy. Most of the drug interactions we see are related to rifampin, and you may see some providers using rifabutin in certain instances because of the fact that the interactions are less. And make sure you're adjusting medications appropriately when they change weight, and also if their renal function changes, that can impact the dosing of some of our medications. So the most common types of adverse drug reactions that we see, the top 4 are listed there: GI toxicity, hepatotoxicity, hypersensitivity, and allergic reactions, and then lots of other dermatologic reactions. Some of the less common ones are listed below that. This is a simplified table of the most common adverse drug reactions to first-line agents. And because so many of our patients are getting a fluoroquinolone, either because of problems with one of the frontline agents, or more recently because we had no INH to give them and they ended up on a fluoroquinolone containing regimen. Quinolones are sort of widely used. So you can see, you can look at this table one of 2 ways. You can look at the drug, or you can look at the type of toxicity that you have. And you can see here that GI toxicity potentially can occur from any of these frontline drugs, whereas a less common problem like optic neuritis is predominantly only going to be caused by ethambutol. So you can look at the symptom, you can look at the drug, and see what things are more common and less common. All right, so what do we monitor for in people who are taking isoniazid? So not quite sure this necessarily fits nicely as a polling question here. So let's, I guess, get rid of the polling question. And you can just put into the chat box what you think you're most worried about with isoniazid.
Do you want me to end the poll, Dr. Framo?
Yeah, why don't you
Okay.
end the poll?
Okay, no worries. I'll just share whatever people have responded
Okay.
so far.
I do have
Okay.
one less common.
Okay, so what are the common isoniazid side effects? And what are the uncommon ones that we monitor?
Hepatotoxicity.
Toxicity. Obviously, the big one is hepatotoxicity. The other one that we monitor for and actually try and give something to try and prevent would be what? Right, so hepatotoxicity and gastrointestinal, right, B6 for peripheral neuropathy. So the most common ones with isoniazid would be both GI toxicity and hepatotoxicity. And for hepatotoxicity, we rely heavily on labs, and we'll talk about that in a second. And for peripheral neuropathy, the only way that we are routinely going to find that out is if you ask. And patients may complain about it. Ideally, we are giving B6 to all of our patients who are on isoniazid for treatment, but it is not completely protective against, you can still get peripheral neuropathy, especially if you have underlying neuropathy. So let's move on. Oops. So what about rifampin? What are the things that we're going to be monitoring for rifampin? Okay, I see somebody's already put in rash and drug interactions, which are going to be very important. And we always ask every visit about new medicines. And we also ask them to tell us if they're starting on any medicines in between visits, just so we know that and can verify them. The rashes are relatively common. Surprisingly, in our population, okay, so orange discoloration of body fluids, yep. And we tell everybody that in the beginning, your urine is going to turn orange, your tears may turn orange, and don't freak out about it. It's going to happen. It's not dangerous. Hepatitis is a little less common with rifampin than with isoniazid or pyrazinamide. We are going to monitor for it, but probably less commonly than we don't necessarily, especially in patients who are getting rifampin for latent TB infection treatment, we're less likely to monitor liver enzymes in most people than we would if they were on isoniazid-containing regimens. So those would be the major ones. Some very uncommon ones. Yep, that's an important one too. The pregnancy issue, and I have a slide, I think towards the end, we'll be talking about pregnancy issues in women on treatment for TB disease and TB infection. Rare toxicities from rifampin are fevers, and one that is very rare, but we see it, is thrombocytopenia, which is one of the reasons why we are monitoring CBCs in patients on rifampin-containing regimens. And the other one that we have seen very rarely, but we've had 1 or 2 cases in the last few years of renal failure from rifampin. So there are a number of uncommon things that we do monitor for. So let's go to our next drug, which is ethambutol. What are we going to be monitoring in patients on ethambutol? Yep, optic neuritis is probably the most important. I showed you the slide of gastrointestinal toxicity, and for some strange reason, we do have some people, we think of ethambutol as a benign drug, but some people point to that one as the culprit when they are having nausea and vomiting, and you stop it and they're better. But the optic neuritis is the one that we monitor for at every visit when they're still on ethambutol. And you're going to do that with visual acuity and monitoring for red-green color blindness. The problem with the red-green color blindness is that a significant proportion of men have baseline color blindness. So they're going to fail their colorblind screening at baseline, so it's harder to monitor them. Okay. And then the last of our drugs, pyrazinamide. What are we going to be monitoring for here? Anything different than we talked about already? Yep, we're going to be monitoring for liver disease. We consider pyrazinamide to probably be the most hepatotoxic of the drugs that we use, and I'll talk more about that in a minute. But it tends to be the one that is most associated with GI toxicity and hepatotoxicity. And there are people who, if they have hepatotoxicity and you stop everything and re-challenge, they will be able to take everything except the pyrazinamide. Any unique symptoms related to PZA? They're a little different than the other drugs we talked about. So the one that we worry about the most or the one that people complain about the most with PZA are joint symptoms. And I can tell you that, they say it's up to about 10%. I think that we have a higher percent of folks than that who complain about the PZA and arthralgias. It occasionally can precipitate gout, but arthralgias are more common. And many of our clients are very happy when they get to that 40 dose mark and their PZA can be discontinued. In quinolones, anything that we monitor for in quinolones? The quinolones are among those drugs that sort of aren't the biggest culprit for a lot of things, but can cause a lot of symptoms. There are many of our folks who don't tolerate a fluoroquinolone from a gastrointestinal perspective. It rarely causes hepatotoxicity, but GI symptoms are common. The interesting thing is that sometimes if they don't tolerate one quinolone like levofloxacin, they may be able to tolerate moxifloxacin or vice versa. But I see the other two, the other symptoms that we worry about that are listed there. QT prolongation is a big concern, less of a concern in people who are not on, have no underlying cardiac disease and are not on any other QT prolonging medications, but especially in our older patients who may be on additional QTC prolonging medications. That's where we worry about it and may have to monitor EKGs. And tendinitis is also not an uncommon symptom, especially in elderly patients and especially in those who are also on steroids. Photosensitivity is not uncommon from quinolones, but some of our other medications can do it as well. And so we always warn people about photosensitivity on most of our TB drug regimens. Okay, so let's move on here. So let's talk briefly about managing adverse drug reactions. And I may not be able to go through all of this because it looks like we are probably running short on time. What time do we end?
We're supposed to finish by 11:15.
Okay, so this is how do we manage ADRs? This is the state of the art. This is pretty much the only tool we have, which is stopping medicines either altogether or sequentially, or maybe re-challenging them. So, I mean, it's really a little bit more of an art than a science, but I'll try and make it a science. So this is back to our client that we talked about who wanted to stop her medicines 2 weeks in. And this is sort of my thought process when I'm thinking about potential adverse drug reactions. The first thing is this an adverse drug reaction? Second, could this be a serious adverse drug reaction? And then I'm thinking, do I need to see them in the clinic? Do I need to get lab work? Do I tell them to stop their medicines? Do I tell them to keep going? Do I tell them to do an intervention like trying an antihistamine? And so there are some people where we can try and muddle through their symptoms, and there are others where we really do have to stop their medications. And if we have to stop medications, do we have to stop one or several or all of their medications? And if we stop them, when can we restart? So that's kind of the approach to any adverse drug reaction. You're going to preemptively monitor. You're going to rule out other causes or other potentially less life-threatening causes. You're going to evaluate how severe the symptoms are. And then you're going to follow up what happens. So back to our client. She feels sick to her stomach. She feels like she might throw up and can't eat, and has lost about 2 pounds since you started her on treatment. You do liver blood work because one of the important points is you often can't tell the difference between GI and hepatic toxicity. So if there's any question, you always get liver enzymes, which are minimally elevated from baseline. So now we have a number of interventions that we can try for her GI toxicity. And we already talked about this. Almost any drug can cause it. The hierarchy typically is PZA and isoniazid are the two highest risk. less rifampin or ethambutol, and quinolones are probably in the middle somewhere. And we already talked about the fact that you may be able to switch them to a different drug in the same class if that's appropriate. And here are some of the strategies that you can do with your medications in terms of modifications of timing, modifications with food. If somebody, especially on a latent TB regimen, isn't tolerating an intermittent once weekly regimen because it's a lot of pills, they may do better with a daily regimen with fewer pills. We can use antacids, and if we need to, we can also use antiemetics. But again, the most important thing is not to ignore the symptoms, because if you don't address them and don't help your clients through them, then they're just going to stop taking their medicine. All right. Now, gastrointestinal toxicity is different than hepatotoxicity. Obviously, this patient here has very abnormal liver enzymes on the bottom. The one on the top has mildly elevated liver enzymes that might not have to stop medication. But the one on the bottom obviously has severe liver enzymes, and there are elevations, and there are criteria to stop them. Okay, and there's a lot of risk factors for hepatotoxicity, and probably you can find one of these in many of our clients. We talked about treatment thresholds. All right. So I want to just talk for a minute about pregnancy. Being pregnant is not a contraindication to taking for treating TB disease. It may be a reason to delay treatment for TB infection, which is generally not as much of an urgent issue, and delaying until more than 3 months postpartum. But it definitely is not a contraindication to treating TB disease. If you start women of childbearing age on on treatment, you want to counsel them about becoming pregnant. Although our drugs are considered safe in pregnancy, it's probably not ideal if they become pregnant, and something that they should avoid if possible. And somebody brought up in the chat that rifampin is going to interfere with the efficacy of some contraceptives, especially orals, but there's a question about some of the hormonally impregnated IUDs and other treatment forms as well. All right. I think that we will finish up here and then sort of address any questions. Just a couple of take-home points. Monitoring, we're monitoring for both response to treatment and for adverse effects of treatment. We can monitor them clinically, microbiologically, and radiographically, especially for pulmonary disease. It is much harder in the clinic sometimes to get the imaging you need to monitor them appropriately if they are having extrapulmonary disease. We worry about drug resistance, but there's lots of other reasons why patients may not be improving, and think about getting drug levels. These are useful tools that I think are underutilized in many clinics. Slow responses are obviously an indication for more prolonged treatment. And it's not because these people are going to fail therapy if they get a shorter course of treatment, but it does mean that their risk of relapse is higher. We like to believe that with our treatment courses that, in the high 90% of people treated with TB will be cured permanently. And those numbers drop, not astronomically, but are definitely a little bit higher if they don't get the appropriate prolonged course of therapy. We talked a lot about adverse drug reactions and that's an ongoing process throughout their treatment course. All right, so let's stop there. And any questions that I haven't addressed?
Yes, there is a question in the chat. Do you lower the INH RIF dose to 5 milligrams per kilogram and 10 milligrams per kilogram in a patient that is about 100 to 110 pounds and has high LFTs, but less than 2 times normal?
So we generally, so rifampin dosing in adults, we almost never modify except if their levels are low, in which case we will increase it. So we generally don't, expect that that's going to make a difference. And generally, we don't decrease the INH dose if they're kind of in that borderline adult range for how many milligrams per kilogram for mild elevations in liver enzymes. It is hard sometimes to use those alternate doses if you're, modifying from 300 milligrams to 250 milligrams of INH. It's not clear that that's going to make any difference. And we generally try and stick to standard regimens in adults.
Thank you. I also have a question just going back to one of your original case studies. At what point would you consider treatment failure? And then what would be the next step if there's treatment failure?
Right. So treatment failure, I mean, if we were, so treatment failure is probably a combination of both clinical and microbiologic treatment failure. If a patient is clinically improving, but their sputums are lagging, we know that can take a long time. And as long as you sort of check the other boxes for there's no drug resistance, they're on appropriate dosing, and they just have extensive disease and need more time, we wouldn't consider that failure. I would worry about treatment failure if I have a combination of both lack of microbiologic response, but also complete lack of clinical response as well. And that can be as soon as 2 to 3 months of therapy. And sometimes there are reasons for that. We do have patients who may have such severe disease that one entire lung is completely destroyed, and maybe they need surgical management to help control their disease, or other reasons why they are failing treatment.
Okay, thank you. That makes a lot of sense. I don't see any more questions right now in the chat, but feel free to put them in the chat if you do have a question. We're at our time about now, but so thanks for hanging on there for a minute. I did put in the chat, you'll see a QR code, and that's a nursing guide, and it says to drug-resistant TB treatment, but it's a really good guide, and they also have an app that you could download, and it really goes through some nursing strategies for side effects and what drugs cause certain side effects. So we did get an overview from Dr. Freymouth, some of our main drugs, and this will give you some of the second line drugs. So I think it's a really good tool for everybody. Thank you, Dr. Freymouth, for doing this. This is always such a great and helpful talk for anybody managing the TB side effects or just and how to monitor TB. With that being said, we are at the end of our session today. We will be back here next week with a talk on infection control by Dr. Sundstrom, 10 o'clock next Friday. And unless anybody has anything else, which I still don't see in the chat, I'm just going to say everybody have a great weekend, a long weekend, because you all deserve it.
Thanks, Dr. Freymouth and Patty. Thanks, everybody. Have a great weekend.